Good afternoon, ladies and gentlemen. I'm Dr. Hsin-Yun. It is my honor to present here, and I would like to thank the committee to let us have the opportunity to share our data. My title today is Performance of HCV Antigen Assay in the Diagnosis of Acute HCV Infection among at-risk people living with HIV. With the highly effective direct-acting antivirals against HCV infection, the WHO sets the ambitious goal to eliminate HCV by 2030. HCV has rapidly spread among people living with HIV who are men who have sex with men sexually worldwide since 2000, initially in European and also in America and the Asia-Pacific region. In our institution, the incidence rate of a recent HCV infection was 2.4 per 100% year in 2018. Furthermore, HCV reinfection is also observed in this population. This slide shows the incidence rate of HCV reinfection among HIV-positive patients in different European cities. In our institution, the incidence rate of HCV reinfection was high up to 8.2 per 100% year. In HCV care cascade, testing and treatment are crucial to halt HCV onward transmission. To diagnose HCV infection, there are three options to choose. The first one is anti-HCV antibody. It is inexpensive and widely available. However, it is unable to distinguish active or past infection and require another test to confirm active infection. It also has the problem of delayed seroconversion in immunocompromised hosts. The second one is HCV core antigen. It is less expensive than HCV RNA testing, and it can detect active infection. However, its sensitivity in HCV RNA loads less than 3,000 IU per milliliter is decreased. The last one is HCV RNA testing. It has high sensitivity with a detection limit of 15 IU per milliliter and can detect active infection. However, it is most expensive. The performance of HCV core antigen assay in the diagnosis of HCV infection among people living with HIV is rarely assessed in the Asian-Pacific region. This study assessed its performance and compared it with that of our three-stage pooled serum HCV RNA testing in high-risk people living with HIV. Our study period is from June 2019 to this February. Our inclusion criteria were people living with HIV without existing HCV viremia who presented with sexually transmitted infection or had elevated aminotransferase within the past 6 months, or had spontaneous HCV clearance, or had achievement of a sustained virologic response after anti-HCV treatment. Our exclusion criteria were people living with HIV with existing HCV viremia. Participants were followed until the detection of HCV RNA, loss to follow-up, death, or completion of 1-year follow-up. Re-enrollment was allowed for participants testing negative for HCV RNA after 1-year follow-up, or those testing positive for HCV RNA and linked to DAA treatment with achievement of SVR or with spontaneous HCV clearance. This is how our three-stage pooled serum HCV RNA testing was performed. It is performed every 3 months or clinical indicated. We put 20 specimens into one tube and tested once for HCV RNA. If the result is undetectable, then all 20 specimens were considered negative for HCV RNA. If the result is detectable, then we combine every 5 tubes into one specimen and test it again. Let's assume this one is positive, then this tube will become positive. Later we will test the 5 tubes individually to identify which one is positive for HCV RNA. The selection criteria of pooled specimen for HCV core antigen were all blood samples at enrollment and all blood samples from the patients with detectable HCV RNA after their enrollment for the pooled HCV RNA tests. During the study period, a total of 3,500 blood samples were collected from 716 patients, and 59 samples tested positive for HCV RNA with the use of pooled HCV RNA testing, leading to the prevalence of HCV viremia of 8.2%. 910 samples fitting the selection criteria, with including 59 samples tested positive for HCV RNA, were subject to HCV core antigen testing. This slide shows the performance of HCV core antigen. Of the 59 specimens positive for HCV RNA, only 52 had a result of reactive antigen. Of the 851 specimens negative for HCV RNA, only 844 had non-reactive antigen results, leading to a sensitivity of 88% and a specificity of 99%, with the prevalence of HCV viremia of 8.2%. Its positive predictive value is 91%, and its negative predictive value is 99%. The HCV viral load of 7 specimens with discordant results between the two tests were as follows. Their median level of HCV RNA loads was 3.2 log IU per milliliter. The percentage of specimens with the HCV RNA load less than 3,000 was 71%. Of the remaining 52 specimens with concordant results between the two tests, their median level of HCV RNA loads was 6.6 log IU per milliliter. The percentage of specimens with HCV RNA load less than 3,000 was only 3.8%. Of the 7 specimens with HCV RNA load less than 3,000, 29% were positive for HCV core antigen. Of 52 specimens with HCV RNA load greater than 3,000, 96% were positive for HCV core antigen. So the higher the HCV RNA load, the more likely the positive HCV core antigen. In conclusion, HCV core antigen assay has a high specificity in the diagnosis of HCV viremia among people living with HIV at risk for HCV infection. However, the sensitivity of HCV core antigen assay is compromised in people living with HIV with a low HCV RNA load. Thank you.